ผมขอเริ่มเซสชันเลยนะครับเพื่อเราจะได้เลิกตรงเวลานะครับสำหรับเซสชันนี้ก็จะเป็น parallel session ในหัวข้อเรื่องของ faculty development system approach institute level and culture นะครับทีนี้รูปแบบของในเซสชันนี้ก็อยากให้ทุกท่านมีส่วนร่วมนะครับเพราะฉะนั้นลักษณะก็จะเป็นเรื่องของการแสดงความคิดเห็นแล้วก็แชร์ประสบการณ์นะครับหรือว่าจะให้ข้อเสนอแนะเพิ่มเติมสำหรับในช่วงแรกผมแล้วก็วิทยากรอีก2ท่านจะให้ข้อมูลบางอย่างนะครับเพื่อเป็นinformation สำหรับการ discuss หรือว่ามองเห็นภาพต่างๆนะครับสำหรับวิทยากร2ท่านที่จะมาอยู่แล้วก็แชร์ประสบการณ์กับเรานะครับท่านแรกก็คือท่าน Professor Ian Cumming นะครับท่านเป็น Chief Executive of Health Education England นะครับแล้วก็รับผิดชอบเกี่ยวกับเรื่องของ Education Training and Development of the Health and Healthcare Workforce ในอังกฤษนะครับ Professor Ian Please welcome Professor Ian อีกท่านหนึ่งนะครับก็คือ Professor Kenji Shibuya นะครับท่านเป็น Professor and Chair of Global Health Policy at University of Tokyo Graduate School of Medicine เป็น President of Japan Institute for Global Health นะครับซึ่งก็จะให้ประสบการณ์ในด้านของทางญี่ปุ่นนะครับ Please welcome Professor Kenjiสำหรับผมเองก็อยู่ที่คณะแพทยศาสตร์มหาวิทยาลัยสงขลานครินทร์นะครับในส่วนแรกผมจะขอให้ข้อมูลนะครับสิ่งที่ผมจะให้ก็คือเป็นข้อมูลที่เราได้ลองเซอร์เวย์ในการจัดการศึกษาของบุคลากรด้านสุขภาพในหลายๆด้านก่อนอื่นอยากจะเรียนในแง่ของการเปลี่ยนแปลงนะครับ reform จะเห็นว่าในแง่ของการศึกษาเนี่ยได้มีการปรับเปลี่ยนมาตั้งแต่ในปี 1900 นะครับตอนนั้นจะเริ่มเป็น science based จนปัจจุบันเป็น system based เราพยายามชิฟจากโรงเรียนไปสู่ระบบสุขภาพนะครับเพราะนี่คือแนวทางของการ reform คือทำไงให้แทนที่อยู่ในห้องเรียนในห้องเรียนก็ไปเรียนในระบบสุขภาพให้กลมกลืนกับระบบที่เราต้องไปทำงานอยู่นะครับทีนี้ส่วนของ faculty development เนี่ยเป็นหัวใจที่สำคัญอันหนึ่งนะครับเพราะว่ามันเป็นการเทรนคนที่สำคัญมากคือครูนะครับเพื่อครูก็จะส่งผลไปที่นักเรียนหรือไม่ก็ resident อันจะนำไปสู่เรื่องของ patient care นะครับเพราะฉะนั้นเห็นว่าอันนี้เป็นความเชื่อมโยงที่มีความสำคัญมากนะครับทีนี้ใน WHO Guideline 2013 ได้พูดเรื่องพาร์ทหนึ่งเรื่องของ faculty development ไว้นะครับอันนี้ให้ definition ของคำว่า faculty development นะครับก็คือว่าเป็นการเตรียมบุคลากรนะครับในฐานะที่เป็นครูเป็น clinician เป็น researcher เป็น investigator ซึ่งสอดรับกับความต้องการหรือวัตถุประสงค์ของสถาบันนั้นๆนะครับนอกจากนี้ต้อง extend ไปถึงว่าแค่นั้นไม่พอนะครับต้อง meet social and moral responsibility to community ด้วยนะครับอันนี้เป็น definition ที่ WHO ให้ไว้นะครับสำหรับ recommendation เกี่ยวกับ faculty development มันก็จะมีอยู่3ข้อที่เกี่ยวกับ faculty development อันแรกก็คือเขาบอกว่า1คนที่เป็นครูหรือเป็น faculty เนี่ยนะครับจะต้องมีเรื่องของ continuing professional development อย่างน้อยคือต้องพัฒนาอย่างต่อเนื่องซึ่งจะนำไปสู่เรื่องของความต้องการของชุมชนนะครับซึ่งอันนี้ก็เป็นหัวใจอันหนึ่งคือบางคนไม่ใช่ว่าเข้าตอนอบรมจันทร์ใหม่แล้วจากนั้นก็หายไปเลยคงไม่ใช่นะครับคงต้องมี continuing professional development นะครับอันที่2นะครับอันนี้ให้ความสำคัญว่าเรื่องของการพัฒนา faculty เนี่ยต้องให้ความสนใจเพราะฉะนั้นไม่ว่าจะระดับของgovernment หรือว่าผู้ให้ทุนหรือ accrediting body ต่างๆต้องให้ความสำคัญแล้วก็สนับสนุนเรื่องของการที่จะพัฒนาอาจารย์นะครับให้สอดคล้องกับ health need ของ community นะครับอันนี้ก็เป็น recommendation ที่2 ในแง่ของ support นะครับ recommendation ที่ 3 ก็บอกว่าอย่าลืมนะครับยังมีบุคลากรอีกกลุ่มหนึ่งก็คือตรงที่ทำงานที่ workplace นั่นเองว่าทำไงเราจะเทรน health community based clinician หรือว่า health workers เนี่ยให้เป็น educator ด้วยนะครับเพราะฉะนั้นอันนี้เป็น recommendation ที่สำคัญในเรื่องของ faculty development ทีนี้ใน dimension ของ faculty development เนี่ยมันก็จะมีอยู่3 dimension อันที่1คือฐานะเป็นครูแน่นอนเราก็ต้องมีศาสตร์และศิลป์ของความเป็นครู pedagogy ต่างๆพวกเราเนี่ยเราจบมาเราไม่ได้เรียนมาใช่ไหมครับเพราะฉะนั้นแต่เราต้องมาทำงานเป็นครูตรงนี้เป็นสิ่งที่สำคัญที่เราต้องพยายามเติมศาสตร์และศิลป์ตรงนี้เติมเครื่องมือติดอาวุธเรื่องของการเป็นครูส่วนที่2เนี่ยส่วนใหญ่เราถูกเตรียมมาแล้วเนี่ยนะเป็น scholar เป็นผู้มีความรู้เป็น professional สกิลพวกนี้เช่นการเขียนเปเปอร์การขอแกรนท์การเขียนอะไรต่ออะไรทำงานวิจัยของเราอันนี้คือ dimension อันนี้อีกอันหนึ่งก็อย่าลืมนะฐานะที่เราเป็นคนก็ต้องพัฒนาความเป็นคนของเราด้วยเช่น time management stress management ต่างๆการทำงานความเครียดต่างๆเราจะทำยังไงอันนี้ก็ต้องพัฒนาตรงนี้ด้วยนะครับเพราะฉะนั้นนี่เป็น3 dimension ของ faculty development ที่เรามาดู situation analysis สำหรับบ้านเราสำหรับ health professional education นะครับอันนี้เป็นข้อมูลที่ได้ลองสำรวจมาเบื้องต้นนะครับอาจจะไม่ได้สมบูรณ์มากเพราะบางสถาบันอาจจะไม่ได้ส่งมานะครับแต่ว่าก็ยังพอเห็นภาพรวมอันนี้ก็เป็นสถาบันที่มีปัจจุบันนะครับคณะแพทย์ตอนนี้มี21สถาบันนะครับบวกกับอีก3นะครับของกระทรวงสาธารณสุขของคณะพยาบาลศาสตร์ก็มีทั้งหมด85สถาบันนะครับคณะทันตแพทยศาสตร์มีทั้งหมดตอนนี้12สถาบันคือ10ของรัฐแล้วก็2เอกชนนะครับอันนี้จำนวนสตาฟนะครับของเภสัชศาสตร์มีอยู่19สถาบันเทคนิคการแพทย์12สถาบันกายภาพบำบัด16สถาบันสาธารณสุขศาสตร์บัณฑิตไม่แน่ใจนะครับเพราะว่าที่ส่งข้อมูลมารู้สึก1หรือ2คณะเท่านั้นเองนะครับแล้วก็อีกส่วนหนึ่งของพยาบาลในส่วนของสถาบันพระบรมราชชนกนะครับก็อีก29แห่งนะครับทีนี้คำถามอันหนึ่งที่ถามว่าสาขาวิชาชีพมีการพัฒนาอาจารย์อย่างเป็นระบบหรือไม่ก็แยกเป็น2ส่วนนะครับส่วนหนึ่งในส่วนของสภาวิชาชีพเองก็มีส่วนหนึ่งก็มีบอกว่ามีนะครับเช่นของแพทย์นี่บอกว่ามีเช่นเรามีการจัดประชุมแพทยศาสตร์ศึกษาประชุมวิชาการด้านแพทยศึกษาทุกปี regular นะครับหรือเรามีการจัดประชุมเรื่องของประชุมแพทยศาสตร์แห่งชาติทุก5หรือ6ปีอย่างนี้เป็นต้นนะครับที่บอกว่าชัดเจนก็มีของแพทย์มีของเภสัชของกายภาพบำบัดนะครับส่วนที่เหลือก็บอกไม่ชัดเจนนะครับในแง่ของสภาวิชาชีพที่จะทำตรงนี้นะครับแต่ของคณะเนี่ยมีเขียนบอกว่าตอบมาว่ามีทุกคณะนะครับมีทั้งในระดับของตั้งแต่อาจารย์ใหม่ที่เข้าไปแล้วก็จัดสำหรับอาจารย์ที่ทำงานปฏิบัติงานอยู่แล้วนะครับคำถามว่ามีการกำหนดกรอบคุณวุฒิอาจารย์และด้านการศึกษาและก็สมรรถนะหรือไม่ทุกแห่งตอบว่าไม่มีนะครับคำว่ากรอบคุณวุฒิของอาจารย์ด้านการศึกษาหมายความว่าprofessional standard ของอาจารย์ความเป็นอาจารย์ทางด้านการศึกษาไม่ใช่คุณวุฒิในวิชาชีพของอาจารย์ซึ่งส่วนใหญ่ที่จะตอบมาก็ถามว่าคุณสมบัติอาจารย์ที่เข้ามาต้องจบปริญญาเอกคือในสายของตัวเองนะครับส่วนแต่ว่าถามว่ากรอบอาจารย์มีกำหนดไว้ไหมไม่มีแม้กระทั่ง competency หรือ skill ของความเป็นอาจารย์ก็ไม่ได้กำหนดไว้นะครับซึ่งอันนี้ก็เป็นสิ่งที่น่าสนใจว่าเราอาจต้องมาตกลงตรงนี้กันว่าคนที่จะทำหน้าที่ของอาจารย์เนี่ยควรจะมีบทบาทหรือว่าควรจะมี framework อย่างไรบ้างแล้วกำหนดคุณวุฒิของนักเรียนใช่ไหมครับบัณฑิตแต่เราควรจะกำหนดคุณวุฒิของอาจารย์ด้วยเนาะนะครับ coming soon นะครับสไลด์อันนี้ก็เมื่อเช้าอาจารย์วิจารณ์ได้แสดงให้แล้วนะครับว่าคำถามที่ถามว่าเราเทรนเขายังไงก็มีหลายรูปแบบนี้ส่วนของเราล่ะเราพัฒนาอาจารย์อย่างไร common approach ที่เราใช้ก็คือ formal group นะครับก็คือเรามักจะจัดเป็นเวิร์กช็อปเป็นเซมินาร์เป็นคอนเฟอเรนซ์เป็นช็อตคอร์สต่างๆที่ less common ที่เป็น individual หน่อยก็เช่นมี mentorship โดยเฉพาะอาจารย์ใหม่ หลายแห่งจะบอกว่าจะมีพี่เลี้ยงให้สำหรับอาจารย์ใหม่นะครับแล้วก็มีเรื่องของ knowledge sharing บ้างนะครับแล้วก็ peer coaching อันนี้ก็เป็นอันที่เราทำกันอยู่บ่อยๆนะครับส่วนถามว่าอันนี้เรา extend ไปถึงครูพี่เลี้ยงไหมอาจารย์พิเศษหรือผู้สอนในสถานที่ฝึกงานทุกแห่งก็บอกว่ามีนะครับมีส่วนใหญ่ก็เป็นลักษณะของเซมินาร์หรือว่าจัดคอร์สให้อบรมให้หรือว่ามีการไปนิเทศงานในสถานที่ปฏิบัติงานจริงนะครับอันนั้นก็เป็นรูปแบบที่ทำกันอยู่เรื่องของการประเมินครูมีไหมทุกแห่งก็บอกมีนะครับทุกสถาบันบอกมีเลยแต่เรื่องของการนำผลมาประเมินเนี่ยยัง question mark บอกว่าไม่ชัดเจนมีการฟีดแบ็กอาจารย์ไหมนะครับอาจารย์มีการปรับหรือเปล่าก็ไม่แน่ใจเหมือนกันนะครับทีนี้ในภาพรวมก็พูดถึงว่าในแง่ของครูหนึ่งแล้วขนาดบุคลากรที่จะเป็นครูนะครับแล้วขาดคุณสมบัติไม่ครบถ้วนก่อนเป็นครูเพราะส่วนใหญ่เราก็เป็น specialist ในสายวิชาชีพของเรานะครับยังไม่มีการพัฒนาอาจารย์อย่างเป็นระบบแล้วก็ขาดการพัฒนาอย่างต่อเนื่องทั้งระบบและกลไกสิ่งหนึ่งที่ยังไม่เห็นก็คือว่าแผนการปฏิบัติแผนการพัฒนาอาจารย์มันสอดคล้องกับบริบทสอดคล้องกับการนำไปใช้การปฏิบัติงานจริงหรือไม่ตรงนี้ก็ยังคงต้องทำความเข้าใจตรงนี้ให้ชัดเจนขึ้นอันที่4ก็คือเรื่องของการทำรงรักษาอาจารย์ที่มีคุณภาพให้คงอยู่ในระบบนะครับอันนี้ก็เป็นประเด็นอีกอันที่เดี๋ยวต้องการอินพุตจากพวกเราทั้งหลายแหละต้องการความคิดเห็นนะครับเพื่อจะได้ไปพัฒนาระบบการพัฒนาอาจารย์ให้ดียิ่งขึ้นทีนี้ในแง่ของการพัฒนาอาจารย์มันมีข้อมูลซึ่งผมคิดว่าค่อนข้างจะ consistent ก็คือว่าการที่เราจัดเวิร์กช็อปจัดเซมินาจัดอะไรต่างๆเนี่ยนะครับถามว่าผู้เข้าร่วมอบรมเนี่ยประเมินดีไหมส่วนใหญ่จะบอกดีทุกอย่างเลยชอบพึงพอใจแต่สิ่งที่ไม่ตอบคือว่าแล้วเปลี่ยนพฤติกรรมหรือเปล่าอันนั้นไม่มี data เลยนะครับว่ามีการเปลี่ยนพฤติกรรมจริงหรือเปล่าแล้วอันที่2คือ outcome ในตัวนักเรียนเนี่ยดีขึ้นไหมนะเพราะฉะนั้นอันนี้อยากจะฝากด้วยนะครับว่าเวลาเราพัฒนาอาจารย์เนี่ยถ้าอาจารย์ดูไดอะแกรมที่ให้ดูอันแรกใช่ไหมครับส่งผลไปที่ตัวนักเรียนอาจารย์ส่งผลไปที่ตัวนักเรียนแล้วก็ต้องส่งที่ patient care ถามว่าการพัฒนาตัวอาจารย์เนี่ยมันส่งผลต่อ patient care จริงหรือไม่นะครับก็อันนี้เป็น research question ที่อยากจะต้องการคำตอบเหมือนกันนะครับว่าอาจารย์ช่วยไปตอบหน่อยว่าอย่างน้อย1นักเรียนดีขึ้นไหมหรืออันที่2อาจารย์เปลี่ยนพฤติกรรมหรือเปล่าอันที่3มีส่งผลกระทบต่อpatient care เป้าหมายสุดท้ายของเราจริงหรือไม่นะครับทีนี้ในฐานะที่ตัวเองสวมหมวกอีกบทหนึ่งทำงานให้ชื่อเนี่ยนะครับสมาคมเครือข่ายพัฒนาวิชาชีพอาจารย์ระดับอุตสาหแห่งประเทศไทยเนี่ยนะครับไทยพอร์ตหรือควทตัวย่อเนี่ยครับเราก็คิดเหมือนกันว่าต้องพยายามทำ professional standard หรือ framework ของครูในระดับอุดมศึกษาขึ้นนะครับโดยที่อันนี้เราก็ได้คุยระดับหนึ่งอันนี้เป็นการเผยแพร่ครั้งแรกนะครับให้อาจารย์บอกแล้วว่า coming soon เพราะฉะนั้นอาจารย์เอามาก่อนนะเผื่ออย่างน้อยใครจะ feedback หรือว่าได้ input เราจะพิจารณา3โดเมนก็เหมือนกับเราสอนนักเรียนนะครับโอเล่ใช่ไหมครับตัวก็ต้องมีทั้งในแง่ของความรู้โดเมนต่างเรื่องของpractice เรื่องของ value เนี่ยนะครับเพราะฉะนั้นนี่ก็เป็นสิ่งที่เราจะมาใช้เป็นตัวพิจารณาโดยเราจะ categorize อาจารย์เป็น4 level คือ A B C D อันนี้ชื่ออันนี้เป็นชื่อแรกๆนะครับเดี๋ยวจะมีการปรับนิดหน่อยให้มันเหมาะสมในโดเมนที่1 professional knowledge เนี่ยเราจะดูสองด้านคือ1อาจารย์มีความรู้ในศาสตร์ของอาจารย์มากน้อยแค่ไหนแล้วในศาสตร์ของอาจารย์เนี่ยอาจารย์รู้วิธีสอนไปสู่นักเรียนไหมนะครับอันที่2คืออาจารย์รู้ตัวนักเรียนคือhow student learn มากน้อยแค่ไหนอันนี้คือ learning pedagogy อันนี้คือในแง่ของ knowledge ที่เราจะประเมินเป็นกรอบคุณวุฒินะครับอันที่2ก็คือ professional practice อันนี้ก็ตรงไปตรงมานะครับครูจะต้องดีไซน์และ plan effective learning activity ได้ ครูจะต้องสอนและ support student learning นะครับครูจะต้อง develop effective learning ครูจะต้อง assess แล้วก็ provide constructive feedback to student learning แล้วก็อันที่7ก็คือครูจะต้อง integrate research ความเป็น scholarship ในตัวของอาจารย์เนี่ยเข้าไปในเรื่องของการเรียนการสอนให้ได้นะครับส่วนเรื่องของ professional value ก็มี3ด้านที่เราจะมองนะครับอันที่1ก็คือเรื่อง continuing professional development ซึ่งอันนี้ก็ได้กล่าวไปแล้วนะครับอันที่2อาจารย์ได้เอาคอนเซปต์ของ QA ที่ทำอยู่ทุกวันเนี่ยมา integrate เข้าไปในเรื่องของการเรียนการสอนมากน้อยแค่ไหนอันสุดท้ายก็คือเรื่องของ professional หรือ personal effectiveness คือความเป็น professional และ personal effectiveness อันนี้ก็จะดูด้วยนะครับอันนี้ก็เป็นเบื้องต้นสำหรับข้อมูลที่จะให้อาจารย์ว่าตอนนี้บริบทของเราเนี่ยเป็นแบบนี้นะครับครับผมทีนี้สำหรับถัดไปก็จะเรียนให้ Professor Ian ได้พูดในมุมมองของท่านนะครับว่าเป็นยังไงครับ Professor Ian please
Thank you very much indeed, ladies and gentlemen, distinguished professors. Sawadi Kap. I'm afraid that's about the level of my Thai, so the rest of it's going to be in English. Before I speak, can I just say a great big thank you for the invitation to come and speak at this event, but also for the really warm welcome that we've received here in Thailand. It has been absolutely fantastic. Thank you very much indeed. It's really appreciated. What I'd like to do is to say a little bit about what we're doing in England to address some of the challenges that we're talking about over these 2 days. And one of the things that struck me listening to the meeting I was at yesterday, and also that's come out already this morning, is just how much we have in common. These are global issues, these are global challenges, these aren't issues that are unique to any one country, and these aren't issues that differ from country to country. So I'm really excited by the opportunity to be able to work globally, to be able to work internationally, to try and take best practice from every country, to bring it together so that we can really end up with something fantastic, and so that we can take forward our thinking and our learning more quickly than if we all tried to do it on our own. So, the organisation that I work for is called Health Education England. We are a new organisation, and we are responsible for educating, training and developing the current and future workforce for our national health system in England. We are perhaps slightly unique in that there is not really any other healthcare system apart from the National Health Service in England. So almost all doctors who are trained, almost all nurses who are trained, almost all physiotherapists who are trained, etc., end up working for the National Health Service. There is a very small amount of private practice, but if you take doctors, for example, 98% of doctors who graduate from our universities will work for our National Health Service. So we have that continuity between education through into employment. And that's the reason that Health Education England, the organisation that I work for, has been established as part of the National Health Service. So my organisation commissions commissions education from universities. It commissions continuing professional development. It looks at determining the numbers of people we need in the various professions in the future. And I'll say a little bit more about that in a moment. But one of the things that we are very keen to say is that the organisation actually only exists for one reason, and that one reason is to improve the quality of care delivered to patients. Because if we start getting down into other reasons, and if we start thinking that we exist to produce the best workforce planning guidance that there could possibly be, we've missed the point. We are here to make sure that we give patients the best possible care we can. So that is what will always drive our organisation. And we do that by making sure that our workforce has the right skills, the right values, the right behaviours but it's also available in the right numbers at the right time and in the right place. So it's proper training, but the right number of people in the right place. And this quote from the Lancet at the bottom of this slide is one that I think particularly resonates with me, that sometimes in our country we tend to focus on technology, we tend to focus on buildings, we tend to think about where the hospitals are located, but actually healthcare is about the interaction between people. Yes, we need the technology, we need the support, but as this quote says, beyond the glittering surface of modern technology, the core space of every healthcare system is occupied by the unique encounter between one set of people who need services and another who have been entrusted to deliver them. So healthcare is about people. That's why I'm privileged to work for the National Health Service organisation that is about people. So what do we do in Health Education England? Well, the first thing we do is workforce planning. What does that mean? Every year I have to produce for Parliament a workforce plan that sets out the demands of our National Health Service for professionals, for the workforce, for the future. If anybody would like to see a copy of last year's, if you leave me an email address, I will gladly email those to you after the meeting. We produce this every year. In fact, this year's will be published on the 16th of December. We produce this workforce plan by going out to organisations, to all the employing organisations, and asking them what is their plan for next year. Do they plan to increase the number of people, number of nurses, number of doctors, number of physiotherapists, number of pharmacists that they employ? Or do they plan to stay the same, or do they plan to reduce? We get that information in from every organisation in the country. We aggregate it up to first regional level and then to national level. And then we apply some calculations to it that look at things such as the average retirement age. So in England, our retirement age is going up, so people are working for that bit longer every year, so we factor that into the calculations. We factor in things like the feminisation of the workforce. We're seeing more and more women become doctors in our country, and actually more of those women are choosing to work part-time or choosing to have career breaks, to have families. Therefore, we need to train more to keep the numbers right in the workforce. And other similar factors around part-time working and things like that, we factor in. We then come out with some numbers at the end of that, which people far cleverer than I would then take and put through a series of calculations to actually work out how many places we need to commission from universities for medical students, for pharmacy students, for nursing students, every profession. And every year, by the end of December, we will then produce these lists of commissions, and they are national numbers, but they're also broken down to a regional level, and we will then go and commission those places from the universities for intake the following autumn. We try not to have big changes from one year to the next, because obviously that doesn't help universities. We try and plan as far as possible over a 3 to 5 year cycle. But just as an example, last year, it was very clear that from our workforce planning that we were not training enough nurses. So last year we took a big step increase, and we increased the number of nursing students going into universities last year by 10%. Looking at the figures, I've already seen some very early figures for this year. I think we're going to be doing the same again. Perhaps not 10%, but perhaps 7 or 8% as another big step increase, because we're not training enough nurses for the demand that we have in our system at the moment. So that's the first area of activity. The second area is really, what do we do with the content of that workforce plan? And we use it to commission education and training from universities. And this is where we have a shared responsibility. And I think we've heard much about this already this morning. So we have a shared responsibility with the universities. We are not experts in education. Universities are experts in education. We have a shared responsibility with our professional regulators. We are not a regulator. We have professional regulators who have that expertise. But we work on behalf of the employers, on behalf of patients in many ways. So by bringing our organisation as the commissioner, together with the experts in the universities, together with the regulators, we believe that we end up with something that is much richer than if any one of those three organisations tried to do it on their own. We do have specific responsibilities. So the university's responsibilities are around ensuring that the academic content is appropriate for the award of the degree. The regulator's responsibility is ensuring that people are safe to go onto the professional register and that patient safety is protected by setting minimum standards. And our responsibility is to make sure that in the curriculum, everything is covered that we want people to be able to do as they come into employment in our National Health Service. So we work on content and we work on numbers. One of the things that has become apparent in our National Health Service over the last few years is that we have focused too much on teaching people. We have a saying in England that for healthcare professionals, we need to educate the head, we need to educate the hand, and we need to educate the heart. And I think many of us would agree that perhaps our emphasis over the last 10 years or so has been too much on the head and the hand and not enough on the heart. And we've had a few failures of basic quality of care being delivered because people were very focused on the technical care and not focused enough on the compassion and on the caring side of it. So one of the things that we've introduced, just launched about 2 to 3 weeks ago, is a focus on attracting and recruiting for values and behaviours. And that's recruiting for values and behaviours into universities, into education, as well as into employment. As I've already said, about 98% of our doctors who we train end up working for our National Health Service. So there is no point in us looking only at employment in terms of have we got the right people. We have to start much earlier on. In our country, to train somebody from day one as a medical student until they become a specialist costs about £500,000. That is a huge, if you count their salary over the time they're training, that is a huge investment in an individual. We don't want to get that wrong. So if you were spending £500,000 on something, you would put an awful lot of time into researching, into making sure you've got exactly the right thing. We had one medical school in England who until recently didn't even meet medical students face to face until they arrived on day one. They did it entirely off a piece of paper. We have said that is unacceptable. So every medical school now, every nursing school, every physiotherapy school, every pharmacy school, for every course that we commission, people have to be interviewed. Over time, we expect there to be patient and public involvement in that selection process. And we're also introducing other selection methodologies such as multiple mini-interviews or situational judgment tests to really make sure that we're selecting the best people, not just academic ability, which is clearly important, but academic ability and interpersonal skills, and skills that we can grow and develop through their professional career. And then the last point on this slide is about lifelong investment in education and training. Although training the future healthcare workforce is critically important, it will take an awful long time to transform our healthcare system if we only focus on the new people. So our National Health Service in England employs 1.3 million people, and we have to make sure that those people are kept up to date, that those people are kept abreast of changes, and that those people are also allowed to develop themselves as teachers, to allow to develop themselves as people who have that broad range of knowledge to be able to pass on to the next generation. If we don't do that, we just continue to do what we've done in the past, and therefore we continue to produce people in our own likeness. And for reasons I'm going to explain in a moment, that's not what we believe we need in England. And I think my favourite quote is that from Henry Ford, who said, if you always do what you've always done, you'll always get what you've always got. And I think that's the situation that we've been in training our healthcare professionals in England for many years now. We've continued to train people in the same way and then wonder why we're not transforming our healthcare system. So if we're going to transform our healthcare system, we have to train people differently, which means the trainers have to be able to do that. And one of the big examples for me is that for many years we have been trying to reduce the dependency in England on hospitals, to actually try and provide more and more and more care in people's homes or closer to their homes through general practice and community services. Yet we continue to train all our healthcare professionals in hospitals. How can we ever create a system that's delivered in the community if all the people we train are trained in hospitals? Because that's what they know, that's what they're comfortable with, that's their default position. So we have to shift the training into the community to be able to then get the services to move out into the community. One of the other areas that I think is important is to look at the past, because the best predictor of the future is actually the past. And future can only be speculation, past can be fact. So what we've done is to look back over a 10-year period between 2002 and 2012 at what has actually happened to the growth in our workforce over that period of time. You have to excuse me, I have to put my glasses on, I'm getting old. So if I show you this line here, this is consultants. This is specialists in our National Health Service. So we have seen somewhere in the region of a 53% growth in the number of specialists employed by the National Health Service between 2002 and 2012. We have just actually got the 2013 information, and the line continues in exactly the same direction. So a 53% growth in doctors working in our hospitals between 2002 and 2012. The next line I want to show you is this one, which finishes here. And that is registered nurses. And registered nurses, we've seen a 12% growth between 2002 and 2012. Now, by and large, in our system, and I suspect it's probably not that different in Thailand, doctors generate a lot of work for nurses. So if we have increased the number of doctors by 53%, yet only increased the number of nurses by 12%, is it any surprise that we now have a real shortage of nurses? Is it any surprise that we now have real problems with all our hospitals clamouring for more and more and more nurses? This wasn't planned, this just happened. Some of the other lines, don't worry too much about the headings at the top and the columns, but basically what they relate to are different periods in the economic cycle of our country. So the first one that's headed Wanless, Derek Wanless was an economist who was brought in by the government to basically look at how we could eliminate waiting times in our National Health Service by investing much more money in our NHS to bring us up closer to the European average. And he started in about 2002. So in 2002, he published his report. The government responded and said they were going to increase real terms funding to the NHS. So if you notice, all the lines suddenly start heading upwards because we're given more money. More money, we train more people, we produce more workforce. We get to 2005, and actually we're spending more than we've been given. So all of a sudden, the brakes are put on spending into our National Health Service by the government, and they say, whoa, 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 you're all overspending, stop, cuts, freezing budgets. So we then had a period of 2 to 3 years where we had no additional investment that we could put into new workforce. And if you look at the lines, the first interesting thing to notice is that it makes absolutely no difference whatsoever to doctors. They just carry on like that. The lines that are impacted particularly are the clinical support workforce, the healthcare support workers, registered nurses, and infrastructure. And by infrastructure, I mean management, finance, those sort of overhead costs. We then come out of that period of no money into a period of investment back in our health service again, and up all the lines go. We switch back on the supply, we go back to universities and say, please train more nurses for us, and back up we go again. And then we come to the global economic downturn that has affected every country around the world, when all of a sudden, 2008, 2009, 2010, we've no money, and the lines come back down again, apart from doctors. Doctors carry on. Now, why? I don't believe it's because doctors are special. Of course, doctors are special, but actually most people who work in healthcare are special. It's because of the length of time that doctors are in training. Because it's such a long period, actually these downturns and upturns in the global economy or in the UK economy don't affect medical training, because we would never stop somebody partway through training and saying, actually, that's it, stop, we can't afford you anymore. So the medical profession has become immune from these global financial challenges. And I think that's a particular challenge for us as we think about our workforce planning in the future. So the question actually that we ask on this slide is, did we mean to do this? Could anybody go back and say, in 2002, there was a plan that in 10 years we would increase the medical workforce by 53% and the nursing workforce by 12%? The answer to that question is absolutely categoric not. This just happened. It wasn't planned. So that's what we're trying to change through our workforce plan. One of the other documents that we've recently published, and again, if people wanted to give me email addresses, I can very happily share this with you. We've just produced a 15-year strategic framework for challenges that we believe are going to face the workforce over the next 15 years. Now, some people think we're mad focusing on 15 years because we won't get it right, and that's absolutely true, we won't get it right. Equally, if we do nothing, we will certainly get it wrong. So our view is that we're producing a 15-year strategic framework of which there are very, very few paper copies around, and that's deliberate. It is an electronic framework that we are continually updating. It has a major review every 6 months so that we can try and keep it fresh, try and keep it up to date, try and reflect changes as they come into being. And the reason we've gone for 15 years is that, on average, it takes 13 years from the day a medical student enters a university until they become a consultant. In some specialties, that is 15 years. And it takes at least 3 years in our system to train a nurse. In reality, it's more than that, but it's at least 3 years to train a nurse. So we have to look into the future. We have to live in the future as an organisation. My organisation spends just short of £5 billion a year, which is a huge amount of taxpayers' money. It's a huge amount of NHS money. And if we get things wrong, we end up making very expensive mistakes. We make very expensive assumptions about what healthcare. So we wanted to start this debate about what are we going to be doing in 15 years. Because if we get it wrong, an undersupply results in unmet need, it results in adequate care being delivered to patients. Actually, it results in increased costs because we rely on expensive locums, or we end up going shopping around the world to recruit people to fill our vacancies, which then doesn't help systems in other parts of the world when we start poaching staff from other countries to come and fill vacancies that we have in our country where we may be in a position that we're fortunate enough to pay more. And we don't believe that's something we should be doing. We welcome anybody to come to our country, but we should be self-sufficient in terms of producing our own people. If we produce too many people, as we have done with pharmacists in England, we have a highly skilled, highly trained workforce that can't get jobs. And we currently have too many pharmacists. We currently have too many dentists in our country. And those are expensive decisions, expensive in terms of money, but they're also very damaging decisions for young people who come out of professional training courses and can't get a job. That's not the position we want to be in. The point I've already made is if we get these decisions wrong, we also lock the way in which we provide healthcare into a very dated model. And we don't want that. We want to be focusing on new models. So hence the reason for the strategic framework. We've grouped the strategic framework around 3 specific areas, and I'm going to say a little bit about each of these. The first is to identify what the global drivers of change are. And these are things that at some time or other in the future will affect every single country in the world. I think different countries may be in different starting points, but we've come up with quite a long list of global drivers of change, and actually they've already been up on the slides you've seen this morning, many of them. They were certainly talked about at the meeting that I was at yesterday, so many of them are no different between Thailand and England. Future patients. We've decided that we would write our strategy based on what do we think the needs of patients will be in 15 years' time, and then work back to what is the workforce that we need to meet the needs of those patients, rather than try and do it the other way around. Because if we do it the other way around, we'll make the mistakes we've made in the past of going with a workforce model and saying, well, patients will have to fit in around that. No. What are the needs of patients? Then how do we train the workforce to meet those needs? And that's the third point on this slide. Having looked at the global drivers of change, having looked at the needs of patients, what does that mean for the workforce? So, some of the global drivers. Money. None of us, none of our healthcare systems anywhere in the world have more money than we need. Just doesn't happen. We could always consume any amount of resource that any government anywhere in the world could ever throw at us. So, to differing extents, to greater or lesser extents, we are always going to have a challenge with money. Genomics I'm going to come back to and say a little bit more in a moment, as I'm demographics and informatics. But social and political factors, they may be different in every country, but they exist in every country. Patient expectations may be different in every country, but they exist in every country. Different service models, changing service models exist in every country. Patients' expectations, I've touched on in terms of future patients. Burden of disease, again, I'll come back to this in a moment. Every country, almost every country in the world is seeing an increase in life expectancy, but that increase in life expectancy is not people who are fit, well and healthy for those extra years of life. It's quite often people who have some degree of illness, some degree of incapacity. Certainly in England, personalisation of healthcare is becoming quite a big issue, that people no longer want to be treated as one of a number of patients with a particular condition. They want to be treated as individuals. And patients are much better informed. Again, I'll say something about that in a moment. Future workforce. The expectations of our workforce are changing. People do not want to work the hours that many of us in this room worked when we were training when we were younger. And I think we just have to accept that Generation X, Generation Y are approaching things in a very different way in terms of their work-life balance and their expectations of work. I've already touched on feminisation of the workforce. We are over 50% women entering medical schools in England now. And that has a huge driver for us in terms of needing to train more people, because women are much more likely to work part-time and have career breaks. I've already touched on community versus acute. So let me just pick on one or two of these in a little bit more detail. And this is the slide that actually reference was made to this morning. This is a patient in her 80s in one of our hospitals in England. That's the hospital bed there. She sat next to the hospital bed. The specialist has just been to see her on the ward round. He's talked to her about her diagnosis. He's talked to her about her prognosis. He's talked to her about her treatment options, and she's just Googling what he said to her to check that he's got it right. Now, this isn't somebody who is 25. This is somebody who is in their 80s. By the way, she's also using her iPad to Skype her family, her grandchildren, to keep in touch with them from her hospital bed. This is unstoppable. We now have the situation in England where for the vast majority of people, if they have a diagnosed medical condition, particularly if it's a long-term condition, or particularly if it's something serious, they will know as much, if not more, about it than most healthcare professionals they come into contact with. That changes the dynamic between the healthcare professional and the patient, because actually, the patient may know more. Are we training people to work in that environment? I think we're at the tip of the iceberg. This is going to grow and grow. You know, I've got an 18-year-old son who doesn't do anything without looking it up on the internet. He spends half his life doing this with his thumbs on games, but he goes to iPad as his first point of contact. We've just been talking in our organisation recently about whether we are going to have to redefine what we call primary care, because we think in future primary care is the iPad. In our country, more young people who think they have a sexually transmitted infection now go to their iPad than do go to see a doctor to look for symptoms. Are we training people for that or not? I don't believe we are. This, and by the way, thinking about how we use technology, the Deputy Medical Director of Great Ormond Street Hospital in London is a consultant paediatric cardiac surgeon. And he tells a story of about 4 or 5 years ago when he saw one of his patients who he'd operated on in clinic. It's a patient who'd been patient for a long, long time. She was about 11, 12. And he saw her in clinic, and she said to him, "Doctor, why can't I Skype you for my outpatient appointments?" He said his first question was, "What's Skype?" When she explained to him what Skype was, he went away and thought about it and realized that for about half of his patients, he didn't need to see them face-to-face in the clinic. So he had the test results, he had the information he needed, and he Skyped them. And what does that mean for the young person? They don't miss school. What does that mean for their parents? They don't have to take time off work. What does it mean for him? He can see an awful lot more patients in his clinic. So he now runs quite a significant percentage of his consultations through Skype. Doesn't do new patients, doesn't do patients immediately post-operatively, but stable patients who he wants to keep an eye on. It's a very good way of him keeping in touch. This exists. This is not science fiction. You can find this on the internet. They're produced by Cisco Systems in the United States, and they're called health booths. You go into the health booth, you sit down in a seat. The seat that you're sitting in is weighing you. There are sensors in the health booth who are measuring remotely your temperature. They're measuring your respiration. Your arm is resting on a pad. It's remotely measuring your hemoglobin. It's measuring your pulse oximetry. It's measuring your heart rate. They're building in additional sensors to start measuring other things, blood pressure, etc., etc. All that information is being transmitted in real time down the line to a healthcare professional who is actually appearing here on this video screen in front of you. You're having a consultation with the triage nurse about whatever it is that's concerning you. If you need an opinion from a GP, from a general practitioner, you're put through in real time to a GP. You have a consultation with the GP. If you need a specialist opinion, you're put through in real time to a specialist. You have a consultation with the specialist. By the way, these healthcare professionals can be anywhere in the world. Globalization of healthcare. As long as they are people who are adequately trained, adequately qualified, they don't have to be in the same country as the health booths. What does that mean to our workforce? That's perhaps a separate debate. If at the end of your consultation you require some medication, you don't get a prescription, the actual tablets pop out of a slot in front of you from a robot that's dispensing behind it, and you take them home with you. Now, I've had this debate with general practitioners, with GPs in our country, and by and large, GPs fall into two groups. This is awful, this must never happen, this is shocking, this isn't safe, is one group. The second group, this is really interesting, this is probably unstoppable, This would be fantastic. This would take 25% of my workload out of general practice, allowing me to spend longer with patients with long-term conditions, comorbidity, with older people, etc., etc. They're in those two groups. Now, my personal view, it's going to happen. I understand that Walmart, big American supermarket chain, are in consultation with Cisco about putting this into Walmart stores across the USA. Of course, the intention would be that you swipe a credit card to use it in America. But if that happens, it's going to become unstoppable around the world. The demand will be there for it. I think the question is whether it's a private demand or a public sector demand. And certainly, I want to see us introducing this into our national healthcare system. Are we training people to work in this environment? Have we really embraced the impact of technology on our future workforce? I don't really want to say too much more about economics because I've talked about that, but I do think it's important that we recognize that we have to become more efficient all the time in what we do, because we are not going to see an increase in funding that keeps pace with what we actually want and need to be able to do. So we predict over the next 5 years in the National Health Service that we will have a gap of about £30 billion between what we think we need to spend and what we're actually going to get. Because we believe over the next 5 years we're not going to see any significant increases in our budgets. We believe they're probably going to be kept at roughly the same as they are now. However, new technology, new drugs, increasing age of the population, etc. I firmly believe that that is eminently doable if only we could find a way of spreading best practice across the country. We have a saying in England in our hospitals that not invented here equals bad. We don't like copying ideas from other places. We like to invent our own solutions. Certainly in my country, if the big hospital in Birmingham comes up with a good idea, there is no way that the big hospital in London will do it because that's Birmingham's. We'll do our own. We'll reinvent the wheel over here. And that's a challenge for us because actually not only should we be sharing in our own country, we should be sharing around the world. There's published evidence that shows that for a new concept, a new idea to become widespread practice in the NHS healthcare system takes 15 years. And by the way, that figure is exactly the same for the United States of America. So that is not a UK phenomenon, that is a healthcare phenomenon. And it's because we usually depend on training the next generation to allow them to take up senior posts as specialists or consultants, at which stage they bring new techniques, new procedures. We've got to shorten that. My ambition is to go from 15 years to 15 months. We already have hospitals in our country who are doing 23-hour length of stay hip replacements. Patients are coming in the morning, they're going home the following morning, they're having a hip replacement or actually now a knee replacement as well. Patient satisfaction is very high, clinical outcomes are very good, and even allowing for the additional investment in staff to care for those people in their own homes, it's £200 to £300 per patient cheaper than keeping those people in hospital for 3 to 5 days. Just think how many fewer hospital beds we need if everybody adopts that model. We're seeing spread, but it's slow. We need to speed it up because it's in the patient's interest and it's ultimately in our interests. This is about the demographic challenges, and we've already heard about this today. Just to give you a few figures, the first person in the world that's going to live to 150 years old has already been born. What are their healthcare needs going to be? In 1949 in England, about half of the population died before their 65th birthday. We now are seeing well over a third of the population who are living beyond 80. We've seen a huge change, but as I've already said, these are people with complex medical conditions. And genomics. For me, this is the biggest single challenge that every healthcare system in the world faces. When it hits us, may be different in terms of where the countries are in investment in this technology. We are, at the moment, in the middle of a big government-run program to sequence the whole genome of 100,000 members of the population by 2016. Beyond that, it's our intention to sequence the whole genome for every single citizen of our country. We are training an enormous amount of people in bioinformatics. We're putting on additional training programs because we believe that this is going to shift healthcare probably more than anything we've seen over the last 30 or 40 years. This, we believe, is going to move us much more towards personalization of healthcare, but also prediction and prevention rather than diagnosis and treatment. Are we training our future workforce for this environment or not? Are we still training our future workforce environment to work in the environment we know at the moment? And by the way, we believe that we will have sequenced the genome for the whole population within 10 years. That means we need to retrain most of our current workforce as well. We can't just focus on the new workforce. So, coming then to the workforce, that point, this has to be current workforce and future workforce. It has to be current workforce because of service delivery, but it has to be current workforce because our current workforce are also the trainers of the future workforce. And if we've not got the trainers of the future workforce thinking about the future, we haven't got a hope of producing the appropriate future workforce. We're looking at some specific areas. So shape of training is a review that we're undertaking of our postgraduate medical training in England. In many of our specialties, it's too long. So if you take anaesthetics as an example, I can say this here because we haven't got any British anaesthetists here. This isn't popular at home. But we spend a lot of time in training people who are going to be anaesthetists. It's one of our longer training programs, and they do pediatric anesthesia, they do neuroanesthesia, they do cardiac anesthesia, they spend significant amounts of time in intensive care. They come out the end of it, and then many of them work as anaesthetists undertaking general anesthesia in a local small hospital. So what we want to do is to look at what do we actually need to train to provide people who are safe and competent, and then if we want neuroanesthesia training or if we want cardiac anesthesia training, we offer that as what we call credentials on top for specific jobs, rather than giving it to everybody and making training programs longer and longer and longer. Role models. For me, this is one of the most important parts of our education and training that we don't spend enough time on. You can provide the finest education and training in the world. You can then allow your students to go out and put them alongside somebody who is a very poor role model for 6 months, and you've lost the whole lot, because they will copy that role model. It is an honor to be a trainer. It is a privilege to be a trainer. It's a tremendous responsibility to be a trainer, because you will produce the next generation. And if the next generation aren't delivering the healthcare that you need, that is in part because of the influence you've had on them as a role model. People will copy you. People will look up to you. I've talked about recruiting for values and behaviours. Alternate study routes, this again is something that we're pursuing in England. We think there's quite a lot of people who, perhaps because of their socioeconomic background or other reasons, they didn't get the right entrance, the right exams to go to university, and we want to try and give people a second chance. So we're introducing part-time degrees for physiotherapy, for nursing, so that people can enter as mature students whilst working and also study, because we're finding that they make really, really good members of the professional team a little bit further on. New roles, let's not be blinkered by what we have, because actually if we started with a blank piece of paper now and said, what do we actually want to run a fully comprehensive healthcare system, we would not come up with the range of professions and specialties that we've actually got at the moment. So one of the things that we're exploring is combined nurse therapists. So people who are physiotherapists and nurses, because we believe that in our society, in our healthcare system, that's going to be quite a useful and interesting role. We're going to start by offering master's degrees in physiotherapy to people who are qualified nurses, and master's degrees in nursing to people who are qualified physios, so that they can both do it either way around. That will be the first step towards actually saying, well, can we do this at undergraduate level? Can we produce somebody who is trained and competent in both areas? There's some resistance to this because we get into professional demarcation. You know, the physios don't like it and the nurses don't like it. But should we allow that get in the way of what's right for patients? Physician associates, common in America for some time, controversial in our country. We've introduced a wide range of physician associate programs now. Where physicians associates are working, they are phenomenally popular. So once people have experience of them, they are great. And actually, they are filling many gaps in junior doctor cover in many of our hospitals, doing it extremely safely, extremely competently. And the last point on this slide is just remember, medical students who are entering university this year are going to be practicing medicine not in 5 years' time, not in 10 years' time, but in 2060. 35 years' time. What's our healthcare system going to be like in 35 years' time? The answer to that is you don't know. None of us can possibly know. So the best we can do for these young people is to train them to be responsive to change, to train them to embrace new ideas, new concepts, to train them to take a few risks. And Bill Gates says that we always overestimate the change that will occur in the next 2 years, and then we get 2 years down the line and think, oh, well, that didn't happen, so, you know, we'll just carry on. But we always underestimate the change that will occur in the next 10. And because of this, we sometimes get pulled into inaction. We have to look 10 years ahead at least to think about the big changes that are coming to get our workforce right. And my final comment, we've got to take some risks. We will get things wrong. But my personal view is if we set on a particular direction of travel and it's wrong, we can change course. If we haven't started, can't do anything. So don't be afraid to take a few risks, set in a direction of travel, change course as you need to. Thank you for listening.
Thank you, Professor Yen, for your clear talk and fruitful information. He talked about the organization named Health Education England, and talk about the global driver for change and a future workforce. So we have the next speaker to talk and share experience in Japan about the faculty development. Please, Professor Kenji.
Thank you very much, Professor Kakura. Following Professor Yan's speech, I am going to talk about a little bit about my experience at the University of Tokyo, because we are also struggling about reform. Reform is not easy. So I'm going to talk about just 3 things. One is World Today, because I'm always happy to be back to Thailand, which is the center of the universe in global health. So we are running many things yesterday and also today. But I'm going to test you, because you know the important thing is performance monitoring. So I'm going to give some tests at the beginning, and I'm going to talk about new challenges and opportunities. So first word today. Do you know this guy? He came to give us a talk at the University of Tokyo a couple of weeks ago. Do you know this person? He's very popular on TED. He's a professor of global health at Karolinska. He's very good at using statistics to, describe the world as of today. So he gave us a test. And because you're a teacher, right? Most of you are instructors, professors, and you are always testing the students. So I'm going to test you using his slides. First thing to understand, the extent of your knowledge about the world today. So how many, first question, what the proportion of the adults in the world can read and write? Simple question, adult literacy. So how many of you think that it's 40% on average, just averaging out from least developed countries to, for example, England, US, so everything, averaging out, population weighted. 40%? 60%? How? 80%? Just 2 people, okay. Second is very easy, because you are a health workforce, you are a health sector professional. What is the average life expectancy of the world's population today? Again, population weighted, averaging out across the population. 50 years? 60 years? Half? 70? 70 years? Not all of them are answering. It's not fair. You have to answer. Only 3 choices. Again, 50 years? Just one. 60 years? Majority, 70. 10%. Okay. Next one, easy. How many of, what's the proportion of the 1-year-old infant in the world vaccinated against measles? Measles vaccination, immunization coverage. 20%. 10 people, 50%, half of the kids are vaccinated. 80%. Again, not all of you are answering, but it's okay. It's not fair. Fairness is very important. You know, participatory, democratic way to teaching is important. Anyway, so the second to last question. In the past 20 years, proportion of the global population living in extreme poverty, defined as, $1.25 per day. Just make it simple. $1 per day has changed. But how? How many of you think that the people living in extreme poverty has doubled over the past 2 decades? Or more or less the same? Or halved? Why you are not answering? Please, it's obligation for you to answer, because you are always testing the students. I'm not judging, I'm not scoring, just raise your hand. So how many of you think that the extreme poverty has actually increased because of the inequality, growing inequality, okay? How many of you think that more or less the same over the past 2 decades? Okay, so how many of you think that actually it was halved? Okay. The final question. Oops. This is the trajectory of the population by the UN up to 2100. So we are here now. Oops. We are here at we are here at around 2010. So how many of you think that the population will continue to increase like a business as usual, simple extrapolation? How many of you think that no more increase? This is about number of children, okay? So it's children defined aged 0 to 14, so aged less than 15. How many of you think that no more increase? Okay, so how many of you think that's somewhere in between? Okay, let's check it out. So adult literacy rate, 80%. Life expectancy is simple, and Thailand is exceeding this, 70 years, on average. Vaccination coverage, quite a few gave a correct answer, 80%. And extreme poverty, actually halved. And trajectory of population of the kids in the world, no more increase, because yeah, nicely articulated, because of aging. So this is the world today. And now I'm going to talk a little bit about our challenges at the University of Tokyo or in Japan in general. So this is the famous university ranking, starting from Caltech and University of Oxford in England, Harvard University, Stanford, and probably Cambridge among top 10, right, always. And University of Tokyo is ranked 23rd, and our reputation is not that bad. Reputation is a little bit tricky, because it is a ranking among the peers. But in Asia, we are still at the top, followed by National University of Singapore and the University of Hong Kong, where Professor Gabriel is heading the university. And I think they are catching up very fast. The problem is our university compared to Hong Kong and Singapore, as you could imagine, these are criteria of ranking. So teaching is more or less okay, but the problem is the international outlook. The red bar is for the University of Tokyo. In terms of innovation, research, citation, impact factors are more or less okay, but international outlook is really a bit tricky. And so fundamentally, we are quite deficient of diversity, as you can imagine, because, for example, proportion of international faculty members, less than 10%. Proportion of female faculty. Here, you have so many female faculties, and Thailand is far ahead of us, only 10%. And international students, nearly 10%. 90% are Japanese. And lectures given in English in just 7%. So it's very hard to become a global university, and we are struggling with it. And also about female participation. Prime Minister Abe, I think he has already announced a snap election today. He is going to dismantle the parliament to have an election next month to, to have a justification from the general public about the Abenomics, his economics strategy. One of which is about women. So he said women's participation, women's role in economic growth is really enormous, which most of the issues I don't agree with him, but this one, particularly womenomics, I'm really believing in it because your participation here is extremely important. But if you look at the reality in Japan, proportion of female researchers is just far behind Korea, and he is a professor here, and Germany and US, of course, and possibly Thailand. Do you know proportion of female researchers here? Do you have any stats? Dr. Sweet? Just a guesstimate. Thailand. No stats? You have a bunch of data. 30%. So you are among the top of the global. Okay. But seriously, the education system is not just the education sector or health sector. It is about a broader social economic environment or reflecting some sort of social values, as Professor Ian mentioned in his nice lecture. And in Japan, there is a rapid decline in student population. It's because of aging and increasing number of universities competing for inferior students. And lots of private schools are going to bankruptcy. And the negative impacts of the university reform since the 1990s. Basically, we are moving toward US education system, probably many of the Thailand or Southeast Asia, or even globally. The system is becoming more like the global standard US education system. So first thing the government has done is kind of dismantling of liberal arts department, which I think is totally ridiculous. But also, the government started deregulation and semi-privatization of national universities without financial base in 2004, a decade ago. That has a huge impact on the universities. We have more autonomy, but we need to compete for grants and also other things. And expansion of graduate school, government pushed to expand the higher degree through the graduate schools, but without the job market. So we have a bunch of PhD unemployed. That's the general status right now. And if you look at the global system, the global burden disease, which also mentioned the burden disease, and this is one of the exercises which I have been working for the past 2 decades. If you look at the global burden disease in 1990, it was mostly, burden among kids and some increasing trend in terms of non-communicable disease. But now it's totally shifted. But still, we have some burden disease, but also we have a bunch of disabling conditions, particularly in developing countries. And this is most, this change in China is enormous. And China is very good at tackling MDG 4, 5, 6. There's a huge burden among children, particularly maternal child health, and TB among young adults. But after 20 years, they nicely tackled it. And they were very successful MDG 4 and some of the TB, MDG 4, 5, and TB, MDG 6. But they have a huge increase in NCDs. Japan has already went through the health transition. And right now, we have a super aging society. We have a bunch of problems about a health system and also maintaining the health systems and also medical cost. This is a health transition result from our global burden of disease in partnership with a bunch of collaborators. This is global. So if you look at the burden of disease, ischemic heart disease and stroke and low back pain among the top, COPD. And of course, infectious diseases are still among the top 10, but it's a double burden of disease, particularly in developing countries. And Thailand has already moved toward more on the NCD side. That's the one thing. It's an epi and demographic transition. But also we need to look at the future of healthcare. I think Professor Yang also mentioned about some of the issues about informatics, but I think there are three. The health sector is becoming a sort of information management sector. That is one. And also, secondly, health sector is not just hospitals or doctors. It is becoming more like integration of life science or life sector. And finally, as I repeatedly mentioned, it is becoming a globalizing sector. What do I mean by information management sector? It is like, as you said, Walmart. It is becoming from individual clinics to group practices, from many small hospitals to a few big healthcare system providers. It is becoming a chain like a Walmart. And what they are going to do is to implement an information management system. And also big data, fiasco about the big data. I have a little bit doubt about the use of big data in healthcare because in the market or sales, it is okay. Use a bunch of data set, analyze it, just look at the correlation and move that direction and test it again and move to different direction. But health sector, because for the big data to be useful, there are three conditions, I think. One is that data is big enough to be analyzed by computer. Secondly, timeliness, freshness of the data set. And then finally, you don't need hypothesis. You just check the correlation, move to that direction, and then check the correlation, move to the other direction. You don't have to test the hypothesis. But health sector is quite slightly different. You cannot just check the correlation of the test or genetics and then move and do some treatment. You need to have some hypothesis, and you need to come up with some differential diagnosis and evidence, and then you have to start treating. So big data would be a great opportunity, but also some limitation in health sector. But still, information management and personalized medicine and the use of a bunch of IT staff is happening. And we do use iPad, cell phone, other gizmos every day in clinical settings. But also that is changing the role of patient, because from a supply side viewpoint to more on knowledgeable, informed patient. That is also change the game, rule of the game. Secondly, integrated life sector. What does it mean? So healthcare was originally developed as an integrated life service in Japan, at least, probably in Asia. For example, we often say that a balanced diet leads to a healthy body. The diet and subsequent drugs, some herbs, are really important in the Asian community. And information management actually facilitates a bigger healthcare system service because of the scale economy. And these systems will do everything from checkups, nursing, they're treating heart failure in the clinical setting, and also dispensing pills. And one of the examples is Cisco's, this automated, system. And like Amazon, it was originally a bookstore, and now it's an integrated e-commerce platform. And that might change the way the health system will be provided. Finally, globalization. But before talking about that, but still, would we make the people particularly elderly population, happier if we give them an iPad, let them Skype with the doctor or grandchildren. But I think people cannot live alone even in a seemingly interconnected modern society. That happened in Fukushima, where I'm working with the evacuees after the Fukushima nuclear accident. So there have been attempts in the temporary housing for evacuees in Soma City, Fukushima. Of course, we gave a bunch, because of the funding from the government to compensate for the damage, a huge amount of money. And of course, people are equipped with a bunch of iPads, cell phone, all the stuff. And every day they are connected. They check the other things. But the problem is, it's not just IT. The people in there need to be connected with other people and the society. And as Professor Ian mentioned, it is about people-to-people interaction. That will make a difference. So it is about to introduce a trust house like this and community supporters to improve social determinants. It is not just a behavior change at the individual level. It is the mixture, socio-economic, environmental change, which might be facilitated through IT technologies, but also we need a little bit more. Finally, globalization. So just to summarize the challenges we have, one is global health trend. Obviously, aging demographic changes are happening everywhere because the global average life expectancy is now over 70, around 74. Now, NCDs and health inequity. These are shaping the global health trends. On the other, we do have a future of the health sector. So the health sector is becoming like a hotel industry. It is, personalized targeting the information, and also, dealing with a bunch of stuff, integrated life sector, and of course, it's globalizing. So the new healthcare paradigm, which we should look at, the mixture of these contexts. At the university, given these changes in terms of the future of healthcare, and also the health needs in terms of burden of disease and aging and health inequity, we are facing some change in social values and demand. First of all, the way we interact has been changed from hierarchy to network. So here is a great opportunity for networking. And I think at the keynote, there was repeatedly mentioned about interprofessional or multidisciplinary approaches. That's what we are talking about. And also from formative to transformative learning. A lot of people are talking about transformative learning, but it's a try and error process. And also, we have to go beyond the traditional way of learning. So David Perkins at Harvard just gave us a talk, and he mentioned about 6 beyonds. So beyond the contents, beyond local to global, beyond topics, beyond the traditional disciplines, beyond discrete disciplines, and beyond prescribed studies. So it is about the same thing about multidisciplinary, interprofessional, and transformative. So here's opportunity. So there are challenges, always some opportunities. But of course, we have to take a risk. And to get the higher position in that ranking, we do advertisement, seriously. But this is not the solution. Advertisement and branding is great. It's very important communication strategy, but it doesn't solve the problem. Likewise, MOOC, web-based training, it's great. Everybody can have access. We do this. But this doesn't necessarily change the world. Of course, the democratizing the lectures, but accessing and more interaction with the student outside Japan, that's great. But that's not enough, I think. But also, we always started a very flat multidisciplinary research institute, which is called CABRI, which is founded by one of the billionaires in the Middle East for the physics and mathematics of the universe. They are just focusing on one single question: what is the universe made of? They are just using mathematics and physics and mumbo jumbo, which I simply don't understand. But they are genius from all over the world and interact. They don't care about the age. They don't care about nationalities, which is quite rare in the context of Japanese education. And here is Transformative Education Health Professional Report in the Lancet, which I also participate in. And Professor Leclerc mentioned about the generation reform. We are focusing on these competency-driven global and local context and system-based learning. So following this, I tried to copy the concept which Fourier Frank and Lincoln Chen developed in partnership with other professionals, and we developed global leadership program. It is a transformative learning objective. Here we started from self, identify yourself, through the global health context, intellectual development, and leadership development. And then interact with group, and in the end, I'm hoping that people are trying to connect with the society, the rest of the system. So it is not just individual development, but it is the interaction of institution and systems. One of the examples of our course is we invite Tachi Yamada, who was the ex-president of Bill and Melinda Gates Foundation on Global Health. And he talked about partnership. He is a very innovative thinker and practitioner and great manager, but also he mentioned about that if you go fast, go alone. But if you go far, go together. So importance of partnership on the basis of his experience in academia, Gates Foundation, and pharmaceutical companies in India. And also we do interaction with private sector and also public sector to think about innovations in global health, like this forum. And also we brought in my friend at Harvard, who used to work at Harvard, Robson Sangay, who is currently Prime Minister of the Tibet government in exile. Why he did run for the Prime Minister in Tibet, abandoning his stable position at Harvard. So we shared about personal views and also personal development. And also invited Marshall Gantz, who is a great communicator and interpersonal skill development person. And people started talking like this and share experiences and develop himself or herself as a kind of leader. And also some of the lecturer and also guest, somebody whom you know very well. He gave us a very passionate and a very informative lecture and talk about importance of networking. So this is it. So I'd like to close my talk with my favorite quote from the John F. Kennedy, his address before the Irish Parliament in 1963. So he said, "The problems of the world cannot possibly be solved by skeptics or cynics." There are a bunch of cynics about the transformative or information technologies and the future of healthcare. And particularly global health or public health in general, because lots of clinicians do not believe in global health. But it's happening. Seriously happening on the ground. And Thailand is far ahead of us. And these skeptics or cynics whose horizons are limited by the obvious realities. But we need men, and of course women, who can dream of things that never were and ask why not. So we are trying to develop these kind of young talent in the future, and we are still struggling, and I am really looking forward to learning from you through the joint learning process. Thank you very much. Kopun Krap.
Thank you, Professor Kenji, for provocative lecture. He talked about the old day, the challenging and the opportunity to reform. So we'll come back to Thai version. ตอนนี้ก็จะเป็นช่วงที่จะเปิดโอกาสให้สักถามอภิปรายแล้วก็เสริมความคิดเห็นนะครับเกี่ยวกับเรื่อง faculty development ในมุมมองหลังจากที่เราได้ information มาในหลายๆด้านแล้วนะครับครับเชิญเลยครับมีไหมครับก็กติกานะครับสำหรับท่านที่จะแสดงความเห็นก็กรุณาแนะนำตัวแล้วก็สถาบันครับมีไหมครับไม่มีอะไรเหรอครับ ครับท่านอาจารย์จรัสมีอะไรจะคอมเมนต์ไหมครับอาจารย์วิจารณ์มีอะไรจะแนะนำเรื่อง faculty development ไหมครับ So you're the speaker. What is your major problem in the term of faculty development in your situation? Major problems in about faculty development in your situation.
Okay, so major problems in terms of faculty development. I think probably the biggest single problem, the biggest single challenge we have is to be able to free people up from the busy day-to-day life that they have, to actually to be able to think about the future, to be able to be retrained, to be able to be reskilled. And we see that both in terms of healthcare delivery as well as developing faculty for the future. We all have busy jobs. And if I go back to actually that example that I gave of the 23-hour length of stay elective hip and knee replacement surgery, the work that we've done looking at why it's taken so long to introduce that is because we think it takes about 3 to 4 weeks at which a team needs to stop doing all elective activity, to redesign their systems, to redesign their processes, and then to reopen their elective activity again. And most hospitals, most doctors aren't able to do that because you can't just stop for 3 or 4 weeks because that's not the environment that our system operates in. Yet the payback, both for patients and financial, is less than a year. So I think we have to change the mindset, we have to change the attitude. When money gets tight in our country, one of the first things that's cut back on is spending on study leave, spending on the ability for people to go and develop themselves, to go and on courses, on conferences, whatever it may be. And actually our view is that when money's tight, when we need to increase the rate of change, we need to invest more in developing individuals, not less. So I think for me, in terms of the faculty development, that's the issue. Are we serious about investing in the people that are going to produce the next generation of the workforce is the first question. And if we are, we have a saying in England, put your money where your mouth is. Invest in it. And we haven't done that to the extent we need.
Thank you. Professor Kenji.
I think it primarily stems from the lack of performance monitoring and also incentive structure, plus showing the return on investment or result. Showing the result. It's very hard to show that, but we have to. So lack of performance monitoring because faculty members do not want to be evaluated anyway. I don't know what's happening in Thailand, but I'm sure you are going ahead. But at least in Japan, there's tradition that faculty members are independent. They don't want to be evaluated. They enjoy the freedom. But that era is gone. So they have to understand that things, rule of the game has been changed.
Could I make one other quick comment, on that? And I think that this is perhaps slightly provocative, but I think it's an important point. If you turn the clock back 100 years, in our country, we had universities and technical colleges up and down the whole country that were working on how to make the gas light more efficient. They were looking on how to make sure that it used less gas. They were looking at how to make sure it didn't get blown out in windy weather. They were looking at how to make sure that there was more light, more lumens coming out for each unit of gas used. And we had tremendous numbers of people working on this. And then someone invented the electric light bulb. It wasn't the people who were focusing on improving the gas light that invented the electric light. And I think there's a challenge for all of us in here that one of the things we need to do is to broaden our thinking, to think outside the box, to bring people in who are going to challenge our ideas, because all of us perhaps at times put blinkers on because of the way we've been trained, because of the environment we've worked in, which is why global meetings like this are fantastic, because I think that brings different ideas, and I'm learning tremendous amount from the Thai system. But you know, we need to look outside healthcare and just have some of our thinking challenged.
มีไหมครับในครับเชิญครับ
I have one question. I think I think the most important success factor is the mindset, to change the mindset of the teacher. So would like to learn from your previous experience, what will be the shortcut to change the mindset of the teacher? Because I think only education or training alone will not be enough for the fast progress. So would like to learn from your experience.
Shortcut. I like to know, but I think it's important, as Professor Ian mentioned, that exposing to something different is very important, and also learning each other from different environment will be quite useful. Because unless I went to the US to get a PhD, I would never thought about like this. So exposing something different from the early phase of your career would be quite useful. This kind of joint learning process and interaction with others would be quite important, I think.
I think there's also something in terms of how we handle change within our organisations. And again, if I'm critical of our National Health Service, we've quite often introduced change by telling people we're going to do something different. So we call it imposed change. So, our government say, we're going to do this. And quite often the natural reaction from the medical profession is, oh no, we're not. And then you get into a long debate, a long argument, which takes forever. Whereas if you actually start the conversation by involving people in the how can we make things better so that the change isn't imposed, it's something that people have jointly, collectively worked on. They then have an ownership of that change, and they're much more likely to buy into it. It's a bit like the the league tables, the performance management debate. If they are imposed on people, then you get reaction. There's a big news story actually running on the BBC today that we're just publishing for the first time surgical outcome data by individual named surgeons. And that is proving to be extraordinarily controversial because it has been imposed. Now, a few years ago, we published outcome data for cardiac surgery, and actually that was published by the cardiac surgeons themselves collectively across the country because they wanted to do it, because they thought it was the right thing to do. It wasn't controversial at all, and it went down extremely well because the group of professionals led it. Whereas this one, it's the government has said we're going to publish it, so we've got huge outcry amongst the profession. And I think that buy-in, that change, that buy-in to the change, whether that's around data or whether that's around how we're going to work, if you don't get that buy-in, you've got a problem.
I have a proposal for the second annual National Health Professional Education Reform. I think we should test some of the approaches by yourself instead of guests will talk to you. But interacting in some small groups, or this discussion about mindset changes would be quite useful. So it's important to share among yourself, learn from peers and colleagues would be quite useful. I don't know, logistically it's challenging, but Thai has an innovative idea always. So I'm sure doctors will solve the problem.
มีไหมครับลองแชร์ประสบการณ์ในสถาบันก็ได้นะครับที่ ท่านทำแล้วก็มีอะไรมีกำหนดกฎเกณฑ์มากน้อยแค่ไหนนะครับหรือต่อไปที่เราพูดถึง professional standard frameworks จะเห็นยังไงมีไหมครับครับเชิญครับ
Dr. Chanchai from ANHPERE Hospital. I would like to ask about your idea of the integrative medicine. Have you ever know something about that? This idea is from America. Integrative medicine.
Sorry, I'm not quite sure that I... Did you say a little bit more?
Integrative medicine means they use everything in the world that can heal people,
right,
according to some evidence base,
right,
some even more, even a little or experience based. And the second question is according to the previous question, I would like to ask about the mindful training. It's also come from America. I'm not sure in Massachusetts or this idea from the Buddhist idea, I think.
Yeah, I think your country and Asian countries in particular are way, way, way ahead of us in terms of this approach. We are a very conservative country when it comes to the provision of healthcare, and we tend to follow a particular very Western, traditional Western approach to the delivery of healthcare. I think we are starting to see much greater investment in what we would call the talking therapies, cognitive behavioural therapies. We have a programme called Improving Access to Psychological Therapies that's about offering people the opportunity to focus on their mental health and well-being as well as their physical health and well-being. But I think we are way behind most of the rest of this world, the rest of the world in thinking in terms of England, and it's an area that we need to address.
มีคำถามไหมครับสักหนึ่งคำถามครับใช่ครับ
Ian, how can you get the health education in England to be so influential?
It's about levers. Now, what we don't want to do is to be an organisation that's seen as telling, because it doesn't work. We're an organisation that we believe we have to work in partnership. And the approach that we're taking is by using three different lines. Incentivise, normalise and penalise are the approach that we use. So if people are doing things that are taking us in the direction that collectively, and I don't mean just my organisation, I mean collectively we believe is right, then we should be incentivising them for doing that. That could be additional funding, that could be additional people, whatever it may be. So it could be additional registrar posts into a particular hospital if they're taking the system in the right direction. You then have the group in the middle who we want to be able to look at that group and thinking, well, actually, if we change, then what are the benefits for us if we teach in a different way, if we provide service in a different way? So that's the normalised group. And then there's a small group who just don't get it. And actually, we need to penalise that group. And we have this year moved all paediatric training from one hospital in England because the quality of training was simply inadequate. And we also had concerns about the quality of care being delivered. We'd given repeated warnings. We'd repeatedly visited, and we were seeing no progress. So we moved every single junior doctor in paediatrics out of that hospital. Within 3 to 4 weeks of us doing that, the whole hospital completely redesigned its paediatric training. So it's not something we'll do lightly, it's something we'll do very rarely, because that's not where we want to be. We want to be in the improvement end. But if we need to, then that's where we are. Obviously, my budget is £5 billion a year, which is an awful lot of money. Of that £5 billion a year, there's about £1 billion of it goes to universities. So that's quite a big lever. There's about £3.5 billion of it that goes into the NHS for salaries of doctors in training or for clinical placements of undergraduate students. That's quite a big lever. But we don't want to use it as too blunt, because if we use that as too much of a lever, it takes us away from partnership working.
Thank you. No? Okay. If we have no more question or comment, I would like to express my sincere thanks to our speaker, Professor Ian and Professor Kenji. Could we please we give a big hand to our speaker? Yeah. Thank you, the audience, and I would like to close this session.